The world of EGFR mutating lung cancers has really changed our management, our understanding, and our choices. So I think we're very lucky and privileged to have choices in this world. We've learned that the EGFR mutation is the most important biomarker in the world of EGFR. We learned that a while ago, but we're learning now really which patient might benefit from which medication. So we have the first generation EGFR TKIs, Gefitinib and Erlotinib. We have the second generation EGFR TKIs, both Afatinib and Dacomitinib. And we even have third generation Osimertinib that is coming up soon. And in fact, one of the most exciting parts of this meeting is the Osimertinib AURA3 data that will be presented tomorrow. But the choices that we have today when we see our patients in that first-line setting, we sort of look at our patients and we ask ourselves a couple of questions. The first question I ask is, what type of EGFR mutation do they have? And I really break it up into three categories: and deletion 19, a 21-point mutation, and then an uncommon mutation. We used to call them rare, but we're really learning that this 10% of uncommon mutations actually makes up a large group. So the first thing we do is look at the mutation. Of course, we look at the patient. Communication, patient education is the key to any therapeutic. We know from the LUX-Lung 3 and 6 data that the 19 deletion had an overall significant survival benefit. And so I think especially in young patients where you can communicate, that deletion 19 with a survival benefit has to be noted. We learned from LUX-Lung 7, even though it wasn't a phase 3 trial, we did see some really interesting results. We did see an improvement that was statistically significant in progression-free survival, time to treatment failure, and probably most interesting for me, that there was almost a 30% improvement in response rate by RECIST criteria for the 21-point mutation. So I think another lesson to be learned is that if we see a patient with that L858R or a 21-point mutation that needs a robust response, then again, Afatinib would be the drug of choice. Of course, there's room for Gefitinib and Erlotinib in the first-line settings. Gefitinib is an easy drug, and in patients who are elderly and patients who live distances away from a cancer center or where communication is poor, then Gefitinib would be a good choice for them. So I think our world is changing. I think what also we're seeing, and we'll learn more tomorrow about the AURA3 data, that in those patients who developed a T790 mutation, the Osimertinib is a perfect drug for them. A prolongation in their survival, a response rate, and an easy, tolerable drug are really key to making these patients live longer. From LUX-Lung 7, in those 14 or 13% of patients in either arm, Gefitinib or Afatinib, that went on to Osimertinib, we're now looking at survivals that are approaching 4 to 5 years. So the future is really bright for our EGFR mutation patients, and we hope this is becoming a chronic disease.